We've been waiting for you. Come on in. It's Talk 10 Tuesday with Chuck Buck and Dr. Erica Remer for November 19th, 2024. Today, Dr. Gerasimos Petratos brings us a technical update on automated physician queries. We'll get the latest coding news from Geiger. Tiffany Ferguson covers the social determinants of health. Tim Powell is at the Tuesday news desk, and Dr. Remer presents her Talkback segment. Now here's the publisher of ICD-10 Monitor, the host of Talk 10 Tuesday, and a man who our players call Coach Prime, Chuck Buck.
Yeah, Prime cut. Hi, good morning, everybody. Thanks, Clark Anthony. Hello, and welcome to the live edition of Talk 10 Tuesday. Good morning, Erica.
Good morning, Chuck, and good morning, everyone.
Yeah. Hey, as you heard, Clark Anthony announced Dr. Gerasimos Petratos is going to join us later in the broadcast. You know, he's the founder of HITEKS. And, you know, he's going to be reporting on advances being made in the area of automated physician queries. And, you know, with the recent release of the 2025 Medicare physician fee schedule, boy, the work those guys do is really crucial, I would imagine.
I would imagine so. We'll see what he has to say.
Indeed. You know, as you know, Erica, we're asking our listeners to send us questions after the broadcast. So, Erica, here's my question for you. Ready? What's your talkback today?
Well, I'm going to do my talk on the OIG and Medicare Advantage and health risk assessments that I was supposed to do a few weeks ago.
Very good. Well, we look forward to your talkback segment. And, folks, we've got a lot of news to report, so we're beginning with Tim Powell. Tim is at the Talk 10 Tuesday news desk.
Today, I'm going to talk about the growing impact of obesity in the United States. So obesity has become a major healthcare crisis in the United States, with rates rising dramatically over several decades. In 1960, fewer than 15% of adults were classified as obese. By 2020, the number had exceeded 42%, according to the CDC. Among children, obesity has grown from 5% in the 1970s to 20% today, reflecting a general issue fueled by poor diet, sedentary lifestyles, and limited access to healthy foods. Obesity continues to a range of chronic health conditions, including type 2 diabetes, heart disease, and certain cancers, leading to an estimated 300,000 deaths annually. The CDC notes that individuals with obesity face a 50 to 100% higher risk of premature death, and it also impacts the mental health as societal stigma can exacerbate depressions and anxiety. Type 2 diabetes, strongly linked to obesity, affects 37 million Americans, with 90 to 95% of the cases tied to excess weight. Heart disease, the leading cause of death in the U.S., is closely connected with hypertension and arteriosclerosis, which both worsen by obesity. The epidemic places a significant strain on the healthcare system as hospitals adapt by investing in larger beds, wider imaging machines like CAT scanners, and reinforced wheelchairs to accommodate heavier patients. The financial burden of obesity is immense. In 2019, obesity-related healthcare costs had reached $173 billion annually. Individuals with obesity incur an average of $1,861 more in medical expenses than those with healthy weight per year. Lost productivity, absenteeism, and the presenteeism future further strain the economy, while employers bear the weight of higher insurance premiums and disability claims. Obesity disproportionately affects certain populations. Non-Hispanic Black adults experience the highest prevalence at 49.9%, followed by Hispanic adults at 45.6%, and non-Hispanic white adults at 41%. Children of Hispanic are at 26.2%, and African Americans at 24.8% face similar disparities. Geographically, southern and midwestern regions of the U.S. report the highest rates, driven by cultural, dietary habits, and economic factors. Addressing obesity requires a multifaceted approach. Public health initiatives like the Healthy Hunger Free Kids Act of 2010 aim to improve nutrition in schools, while some cities have implemented soda taxes to curb the sugary drink consumption. Communities and workplaces increasingly promote wellness programs involving physical activity and healthy eating. However, structural barriers such as food deserts and income inequality remain significant challenges. On an individual level, adopting balanced diets and active lifestyles is essential. But systemic change is needed to make these options accessible to all. Collaboration among policymakers and healthcare providers and educators is critical to reversing this trend. So in conclusion, obesity in the United States is a complex issue with far-reaching implications for health, the economy, and the healthcare system. Rising rates have increased the need for specialized medical equipment and services, further straining resources. A comprehensive approach addressing both individual behaviors and systemic barriers is essential to mitigating the growing impact of obesity and to create a healthier future for all Americans. And with that, back to you, Chuck.
Thanks, Tim, very much. That was Tim Powell. Tim is a compliance expert, and he serves as the national correspondent for ICD-10 Monitor. It's Tuesday, it's November the 19th, and you're listening to the live edition of Talk 10 Tuesday. Stand by.
Achieving effective collaboration between CDI, coding, and quality departments is essential for improving patient outcomes and financial performance. Join renowned expert Angela Comfort as she addresses these challenges and provides actionable strategies to align CDI, coding, and quality departments more effectively. Angela will share insights into creating cross-departmental communication strategies, establishing shared KPIs, and leveraging technology to enable seamless data sharing and collaboration. Her webcast is this Thursday, November 21st at 1:30 p.m. Eastern. The session offers essential strategies for breaking down silos and achieving cohesive teamwork to advance the organization's goals and enhance patient care quality. Register now to attend. Go to the ICD University bookstore for your admittance to this crucially important webcast.
Now's the time for the Talk 10 Tuesday Coding Report with Christine Geiger. And good morning, Chris.
Good morning, and thanks. While it's not in the news anymore on a daily basis, COVID has not gone away. Since the start of the pandemic, we have seen waves of infection and different variants. While there may be a lot of things about the COVID pandemic that we would all like to forget, our coding guidelines should not be one of them. Today, we're going to revisit some coding COVID guidance. An article in Prevention last month identified the XEC variant as the latest variant spreading throughout the United States. XEC has been detected in the US and Europe after being first identified in Germany, June 2024. This variant is thought to be a hybrid of the Omicron subvariants KS1.1 and KP3.3. KP3.3 is in the family of flirt variants, and KP3.1.1 is still the dominant strain in the United States. These variants were seen during our summer wave of COVID cases. According to Yale Medicine, as of early this month, the XEC variant accounted for an estimated 28% of all COVID cases in the United States. The KP3.1.1 variant accounted for an estimated 52% of all COVID cases in the United States. Taking a look back at COVID coding, we're all familiar with the U07.1 code for COVID-19. As you probably remember, this code was effective as of April 1, 2020, as part of that unprecedented off-cycle update to the code set. This was necessary to respond to the pandemic. This is considered an MCC for MSDRG grouping purposes. There are two use additional code notes on U07.1. One guides the coder to use additional code to identify pneumonia or other manifestations such as, and it lists pneumonia due to COVID-19. The other instructs the coder to use additional code, if applicable, for associated conditions such as, and lists COVID-19 associated coagulopathy, disseminated intravascular coagulation, hypercoagulable states, and thrombophilia. According to the official guidelines for coding and reporting, these use additional code notes indicate the proper sequencing order of the codes, etiology followed by the manifestation. In the tabular index, there will be a code first note on those manifestation codes. Pneumonia due to COVID-19 is assigned to J12.82, pneumonia due to coronavirus disease 2019. This manifestation code will be sequenced after the U07.1 COVID etiology code. J1 2.82 took effect as of January 1, 2021, again with an off-cycle update to the code set in response to the ongoing pandemic. Other COVID-related codes were also included in that update, including our personal history of COVID-19 code Z86.16. Another important thing to remember is that we only code confirmed COVID-19 cases. Official guidelines let us know that this is an exception to the hospital inpatient guideline. It further instructs that a positive test result is not required here, and the provider's documentation that the patient has COVID-19 is enough. If a provider documents COVID as suspected, possible, probable, or inconclusive, we would code any signs and symptoms reported and not U07.1. In the weeks ahead, we're going to take a look at long COVID and coding for those post-acute in conditions. Back to you, Erica.
Thanks, Chris. That was Christine Geiger. Christine is the Assistant Vice President of Acute and Post-Acute Coding Services for First Class Solutions.
Now your coding team can actually enhance its interventional radiology coding in 2024 with an exclusive starter kit from MedLearn Media. The new Interventional Radiology Starter Kit includes the popular ebook Essentials of Interventional Radiology Coding, plus electronic interventional radiology coding charts, and the latest webcast, 2024 Basics of Interventional Radiology Coding. You get all three tools in the new Interventional Radiology Coding Starter Kit. Order your Interventional Radiology Coding Starter Kit today and start seeing amazing coding results. Now available at the ICD University Bookstore.
Now's the time for the Talk 10 Tuesday report on the social determinants of health with our good friend Tiffany Ferguson. And good morning, Tiffany.
Good morning, Chuck. Good morning, all. So today I'd like to report on CMS's release of the new conditions of participation for obstetrical services. So they threw this out in the 2025 OPPS final rule of specifically calling out obstetrical services, specified conditions of participation for hospitals and critical access hospitals. This initiative is part of CMS's strategy to improve maternal health outcomes, particularly considering the United States' ongoing maternal health crisis, which has resulted in some of the highest maternal mortality rates among high-income countries and disproportionately affects communities of color. There are about 6 provisions in here. They are coming out in a phased rollout, which I'll end on. Let me just go through the details for you guys so you have this information. So first is specifications on organization and staffing. CMS has finalized requirements ensuring OB services are well structured, adhering to nationally recognized standards. The OB care department and units must integrate with other departments in the facility, and OB patient care units must be supervised by qualified personnel, such as experienced registered nurses, certified midwives, nurse practitioners, or physicians. The granting of OB care privileges must follow written criteria, ensuring that only appropriately qualified practitioners provide OB services. So there has to be a guarantee of that in writing and policy and practice. Delivery of services. To ensure the effective and timely treatment of obstetrical cases, CMS requires that facilities maintain essential OB equipment, such as fetal monitors and cardiac equipment. This level should reflect the facility's volume and complexity of OB services. So some way of kind of demonstrating how you're maintaining par levels for that supply and equipment on those units that aligns with the volume of services that you're providing. They did call out, they understand low volume facilities, and obviously they don't need to have as much required. It just needs to be put together in some type of policy or standard that you're listing of what you're identifying there. Staff training. CMS mandates that hospitals and critical access hospitals will develop training policies tailored to the specific scope of services for obstetrics. The training must provide be evidence-based and informed by the facility's quality assessment and performance improvement QAPI programs. New staff must receive initial training, and relevant existing must complete training every 2 years. Quality assessment and the performance improvement program, they are requiring that this address specifically health disparities among OB patients. So facilities are now going to be required to analyze data and provide quality indicators across different subpopulations, measures and track patient outcomes, prioritizing initiatives to reduce disparities. At least one performance improvement project on OB patient outcomes is required annually now. Enhancements to emergency service readiness. So CMS has revised emergency readiness standards requiring that hospitals and critical access hospitals have provisions aligned with nationally recognized guidelines and treatment of emergency patients relevant to pregnant and postpartum women. And then finally, the discharge planning requirements. So it called out specifically CMS is recommending adding transfer protocols to the discharge planning conditions of participation 482.43. However, this is listed only in the obstetric service. So we'll see how this kind of aligns with next year and other things for the conditions of participation. What they're including is some mandates related to intra-hospital transfers and transfers between facilities. So they're wanting to make sure that there's an inclusive process for hospital inpatients, for example, transfers from the emergency department to inpatient admissions, transfers between inpatient units in the same hospital, as well as transfers between inpatient units to different hospitals. So in this, there is a 3-phase approach. The first is phase 1, 6 months post-rule effective date. They will be requiring standards for the emergency readiness and the transfer protocols. In phase 2, that'll be 1 year from the effective date will be organization, staffing, and delivery of OB services. And then phase 3 will be a 2-year requirement for OB staff training, full implementation, and the QAPI programs for OB services for quality initiative and data tracking. And with that, back to you, Erica.
Thanks, Tiff. We're going to have to see what happens with the next administration and how these rules get changed. That was Tiffany Ferguson. She is the CEO of Phoenix Medical Management.
As you heard us mention at the top of the broadcast, the producers of ICD-10 Monitor and Talk Net Tuesday invited Dr. Gerasimos Petratos to provide us with an update on the automated physician query process. And good morning, Jerry. Welcome back.
Good morning, Chuck. It's great to be here. I wanted to talk to you this morning around the physician fee schedule. Before I get into that, I did want to mention about how doctors from their time in medical school are really not trained to learn CDI or coding, even though they are essential to strengthen the integrity of their documentation. They typically learn some CDI and coding while they start training, but many hospitals choose to target the more experienced hospitalists or attendings rather than the residents and community physicians. So depending on the type of institution, for example, academic medical centers, AMCs, versus community and for-profit facilities, we're seeing different types of CDI needed. I'd like to show the first slide from the slide deck that I put together. So essentially, there's these 5 general groupings of CDI areas. One is attribution of one problem to another condition, like when a patient has delirium and the provider needs to put that in association with encephalopathy, another diagnosis. Specificity is a very common one. Reconciliation of diagnosis discrepancy from other clinicians is also common. One provider says sepsis, another one says septic shock, and the role of CDI is to help reconcile those with the physician. And then clinical validation, that's when a stated diagnosis does not have the clinical indicators in the record. For example, acute respiratory failure when the blood gases are within normal range. And finally, suspected diagnoses, when calculated clinical indicators indicate and other signs and symptoms may indicate likelihood of a diagnosis, but it's not hasn't been stated yet by the provider. Acute blood loss anemia is a good example. So the reason I mention this is that different institutions have different prevailing need for this kind of CDI. For example, AMC's diagnosis reconciliation seems to be a prevailing issue, whereas clinical validation and attribution are more common in community and for-profit hospital settings. So the more we study these, the more we can target appropriate education and training to optimize them. Now, shifting to the Medicare physician fee schedule, as you may know, since 1992, Medicare payment has been made under this schedule for services of physicians and other billing professionals. The latest 2025 update is that there will be much more emphasis on social determinants of health in terms of the risk assessment that payers want and need to provide to help reimburse providers. Unfortunately, telehealth will be limited with geographic and location restrictions similar to the way they were in place before COVID. And what we're seeing is that primary care through advanced primary care management services are getting new codes. So there's 3 new HITEKS codes associated with those services: principal care management, transition care management, and chronic care management. And unlike regular care management codes, there's no time-based threshold on these elements. So the new APCM codes are stratified into 3 levels based on an individual's number of chronic conditions. So this is where the HCC type of codes become very, very important. So the idea is that the taking into account of these codes will help strengthen the primary care payment system, and so this is the main thing I would say to look out for when it comes to the updated physician fee schedule. So appreciate you bringing me on the show, and I'll toss it back to Chuck.
Thank you very much, Jerry. That was the founder and CEO for HITEKS, Dr. Gerasimos Petratos. Now here's Dr. Erica Remer with her very popular segment. It's called Talk Back. Dr. Remer, it's all yours.
Thanks, Chuck. So my companion article to this was published a few weeks ago, but we didn't have time for my talk back that day, so here it is. The Office of Inspector General came out with a report October 2024 entitled Medicare Advantage: Questionable Use of Health Risk Assessments Continues to Drive Up Payments to Plans by Billions. This report interested me on several levels. As a person rapidly approaching Medicare age, I found the statistics offered interesting. In 2023, 32 million Medicare enrollees, who constitute about half of 65.75 million Medicare beneficiaries, chose MA, Medicare Advantage, Medicare Part C plans. The costs to CMS were $448 billion of the total $1 trillion in cost, which seems to me to be just south of what the proportional costs would calculate out to be. We use my cell phone number as my father with advanced dementia's contact number. He is not able to answer his phone reliably, and he does not have the understanding or executive functioning to respond to a phone call. As a result, I frequently get calls from United Healthcare's House Calls program. They are not affiliated with my father's primary care provider, who happens to be hospice at this time. They bill this as a, quote, opportunity to ask questions and get answers about the things that matter most to you about your health, close quote. They offer up to an hour of one-on-one time with a healthcare practitioner, a physical exam, healthcare screenings, a medication review, and an opportunity to get advice, education, and have your questions answered. At the end of the visit, you are supposed to get a personalized checklist of items to discuss with your PCP. I call BS. My take is that this is a mechanism to try to inventory a client's medical conditions so the payer can maximize risk adjustment factors. The benefit is to United Healthcare's capitation, not to my father's health. What do they think their nurse practitioner will unmask that a competent PCP would be heretofore unaware of? When I decline on his behalf because there is nothing to be gained for him, and it will just be a waste of my time, they offer to see him without me. Now, exactly what information are they planning to derive from that visit? The report states that diagnoses reported only on an enrollee's health risk assessments and HRA-linked chart reviews resulted in an estimated $7.5 billion in Medicare Advantage risk-adjusted payments for 2023. If a diagnosis is only found in a health risk assessment, HRA, and not noted in any following service, one of two likely scenarios are in play. Either the diagnosis is in error, or the patient is not receiving necessary treatment for a valid condition. If diagnoses are added without intervention, follow-up care, or care coordination to address those diagnoses, why should the provider be allotted more Medicare dollars, presumably for the treatment of the chronic conditions? The details of the diagnoses claimed and the payers, which were the major culprits, can be found in my article, which was a few weeks ago, and in the OIG report. OIG's recommendations to CMS were that there should be actions associated with diagnoses that result from HRAs, that ongoing risk adjustment data validation, RADV, audits should be undertaken, and that the use of diagnoses reported only on in-home HRAs or chart reviews be restricted. The only recommendation that CMS agreed with was to determine whether select hierarchical condition categories, HCCs, are more prone to misuse among MA plans. Prior to my father's deterioration, when he lived in an assisted living, I visited him one day and found a house calls mug, magnet, printout, and a Visa gift card. They had visited him without discussing it with me, and I suspect they didn't get much valuable information. The gift card was a nice touch, though. Even though he isn't listening, happy birthday to my oldest son, Scott, who turns 31 today. And with that, Chuck, back to you.
Wow, Erica, thanks very much. And folks, that is going to be a wrap for this, our live edition of Talk 10 Tuesday. And I want to thank our panelists today. I want to thank Tiffany Ferguson, Christine Geiger, Tim Powell, Dr. Gerasimos Petratos, who reported our lead story, and a very special thank you to you, Dr. Erica Remer. Until we meet again next Tuesday, I'm Chuck Buck, reporting for ICD-10 Monitor and Talk 10 Tuesday. Have a great week, everybody.
Talk 10 Tuesday is a production of ICD-10 Monitor.